Welcome and good morning, everyone. I hope you're well on this sort of misty March day and curl up with a cup of coffee or whatever makes you warm because we have a wonderful speaker today, Dr. Natalie Crawford, and I will be introducing her shortly. Let me first share a couple of announcements. On March 21st, we have a webinar with our very own Health Equity Core and Stats, Data Science, and Management Core fellows and alumni and members. Doctors Justin Knox, Jennifer Moots, and Amy Campbell. Their webinar is entitled Implementation Curious, Considerations when Applying Hybrid Designs. Also, just another shout out for the podcast that has been developed by the Stats and Data Management Core called Analytic Angle. There's currently 4 episodes as part of this podcast that cover pilot studies, stat programming, and grant preparation logistics. So fellows, HIV center investigators, if you're interested in submitting grants or articles or anything scientific or research, please check out this podcast. They'll be exceptionally informational. Also on April 4th, we welcome back Dr. Morgan Philbin. As some of you may know, Morgan was a T32 fellow, and she'll be presenting her work on long-acting injectables. And that's on April 4th. Also, just a shout out, we do have psychologists and for social workers continuing education credits. And Chris will send out the link to the survey at the close of our discussion today. But I would really like to welcome Dr. Natalie Crawford. Dr. Crawford is an associate professor in behavioral, social, and health education sciences at Emory University Rollins School of Public Health. And she also co-directs the Prevention and Implementation Center, or CORE, and the Center for AIDS Research. I have held the same position and was at Emory. I think as I was leaving Emory, Natalie, you came to Emory. So it's good to see that the CFAR is in great hands with you. Dr. Crawford, I think we can claim her a little bit ourselves. She received her master's and doctorate in epidemiology here from the Columbia University Mailman School of Public Health. She completed her postdoctoral training at the University of Michigan as a Robert Wood Johnson Health and Society Scholar. She's a graduate of Spelman College, where she was trained in women's studies and biochemistry. Dr. Crawford's NIMH-supported research examines structural interventions in pharmacies in reducing racial inequalities in HIV. Honestly, Natalie, when we asked HIV Center members who they would like to see, your name was upon the top of the list. So it's really exciting to have you. It's really, your research is remarkable, and we're just excited to hear it. And so without further ado, Dr. Natalie Crawford.
Thank you for that introduction, Gina. It is, Dr. Wingate, it's absolutely amazing being able to have the opportunity to present to you all today. I have my Columbia robe in the back, and so I'm always representing from Columbia, and it really feels like a full circle moment to have the opportunity to share my work with you all. This is my first official coming home with my research, so thank you, and it's really an honor to be invited by you, Dr. Wingate. I've looked up to your research, as you know, for many, many years, and although we overlapped, I think, for just like 2 weeks at Emory, it was nice, and it has been really nice to remain in touch. So thank you. So I will share my screen if that is okay. All right. I believe everyone should now see just my slides. Is that correct? And not the slides with notes. Okay, perfect. Okay, so today I want to just thank you all for taking the time to be here and learn more about this work. I'm going to talk about pharmacy-based approaches to improving equity in HIV and substance use-related harms. And I don't really need to give a ton of background here for this group, but I am going to. Before I start, I want to just note that I don't have any disclosures. So I'll start with just a little background. I'll give you a little bit of the epi of HIV by race and ethnicity, and talk a little bit about substance use, sex and substance use risk behaviors by race and ethnicity as well. And then I'm going to spend more time really walking you through basically my entire research career, which is long, well, one umbrella of my research career, which is really mostly been in pharmacies to try to reduce racial inequities in HIV. And it started in New York, and I'll talk about that in a little bit. So everyone knows that there are stark racial inequities in HIV. More than 40% of new infections occur among Black people, followed by the next highest group is Latino people. By risk transmission group, we know that this is mostly driven among gay and bisexual men, particularly Black and gay and bisexual men. And among each risk group, Blacks are generally most likely to bear the burden of HIV, with the exception of people who inject drugs most recently. Counterintuitive to what we would expect, however, sex and substance use risk behaviors have not explained these racial inequities for the longest. And so this has led the field to really try to understand what is happening. So racially minoritized populations have lower sexual risk behaviors and drug risk behaviors. And I'm going to show just a few slides of data that are older data that we've seen from quite some time, but consistently prevalence of condom use during last sexual intercourse among Black populations is higher for both men and women compared to white populations. The proportion of people who use drugs by race ethnicity is slightly lower for Black populations compared to white populations, and much lower for Latino populations. And when we do use drugs, we are less likely to use them in a risky manner. So this shows receptive syringe sharing among people who inject drugs, and the reference group being Black people. You see that Latinos and white individuals are significantly more likely to receptively share syringes, meaning that they would be receiving a syringe that might likely had some possibility of blood that would infect them with HIV. And so on the backdrop of all of this, we know we have some amazing behavioral and biomedical interventions. Dr. Wingood has done a lot of this work. There are a number of you who have done a lot of this work for decades. But what our problem has been is that there are unsustainable effects on the individual level. So we see these incredible interventions that are able to change behaviors. And unfortunately, oftentimes behaviors sort of end up going back to what they were at baseline or close to that, right? And so they'll last for a few months, 3 to 6 months, and then sort of trickle back. The other thing that we see is that there's unequal distribution by race. So we are able to increase syringe access, but this often happens disproportionately for white populations compared to Black populations. We're able to, and I'll show in a second how we're able to increase PrEP, or we have PrEP, which is amazing, but this is disproportionate. HIV treatment and Hep C treatment, and we see this along the lines. And so just for PrEP, I know most of you have seen this figure by now. Only 25% of the people who are eligible for PrEP were prescribed in 2020. But this is disproportionately among white people. Only 9% of Black folks and 16% of Latino folks were on PrEP, although they would have been eligible, versus 66% of white folks. This figure will probably be disseminated much more. This is an update on PrEP prescriptions among those who could benefit. And this shows from 2019 through 2020. You just saw that 2020 data, right? Well, since then, those inequities have increased. And while this is an amazing success story for white people, this is a failure among Black populations and Latino populations. And so what we have to really reckon with and figure out is how we are working on interventions that reach everyone, particularly those who are at the highest risk of HIV. And so a lot of my research is really guided by this structural model of health behavior, right? This is from Cohen, where we have a distribution of the population. And a lot of times our interventions are sort of here at this individual level line. I'm not sure if you all can see my slide, but there's an arrow that's pointing to it, right? We are targeting our intervention at one population in one context at one time, right? And so what we will see is that those individuals who are targeted may have some change, but what our real goal should be is shifting the distribution for the entire population, which would require us to have broader interventions that affect everybody across all contexts over time, right? And so the target of individual level interventions minimizes what we can actually achieve. While they are important, it has not proven to be the most successful approach, particularly for reducing racial inequities in HIV. And so our targets really need to be on a structural level. Cohen argues that there are 4 areas that this can be. This is the availability of services. And so this is increasing access. So increasing the ability for people to get to services. This could be changing the physical structure of some intervention. And so an example of this could be shifting from oral PrEP to injectable PrEP, something that would be able to reach people easier. Social structures or policies. We know that policies can affect blanket the entire population. And then media and cultural messages. These are things that could be disseminated widely, and whether a person needs it or not, they are receiving and processing those messages. And so this is the way that I really am thinking about how we need to move forward in the field with combining our amazing biomedical interventions, incredible behavioral interventions with structural interventions so that we are able to ultimately reduce racial inequities in HIV and have some impact. So just to define this for you, structural interventions are those that target the economic, social, contextual, policy, or organizational level factors that have increased risk or protection against HIV. Now I'm going to move into, with that anchoring, I'm going to move into some of the studies that we've done in this area, specifically around pharmacy. So I think a lot of times, and this is not as much anymore, people used to ask, what are you talking about with pharmacies? What is the role of pharmacies in HIV, right? We are accustomed to thinking of pharmacies as dispensaries, right? We get our meds from there. But until 2020, we hadn't really thought about them broadly. We hadn't thought about them for much else other than medication dispensing. Thankfully, you know, one of the positives from the COVID pandemic, which there weren't a lot, but that was one. This is one that we were able to see how pharmacists and pharmacies really fill the gap for the larger medical system, right? Like you were able to go in and get tested for COVID. You were able to get a vaccine with little to no notice, with no appointments, right? And it really was allowed services, health services, to meet people where they were in their own communities, right? So we've been thinking a lot of my colleagues, we've been thinking about how pharmacies can play a role in HIV prevention for quite some time. And I'm very lucky that we started in this work, and grateful that we started in this work through harm reduction. This is an old map, and if there are any colleagues on this call that have seen this map updated, please share it with me. CDC put it out a while ago. I can't find it on CDC anymore, but I keep it. It basically shows states that allow the retail sale of syringes in pharmacies, states that have policies. And I was very lucky to be a student at Columbia when New York was one of the very first states to allow the sale of syringes in pharmacies, specifically to reduce HIV and infectious disease among people who injected drugs. That was their explicit goal with this program called the Expanded Syringe Access Program. I was also very grateful that I had the opportunity to, shortly after this program was implemented, work at the New York Academy of Medicine. The New York Academy of Medicine, I worked there while I was a student at Columbia. NIAM evaluated the ESAP program in collaboration with Beth Israel and NDRI. And they wanted to evaluate whether or not a number of things, whether or not this was actually reaching people who inject drugs, whether there was increased, there's always this argument for some folks that, you know, if you increase the ability for people to use drugs, they will use more. They wanted to see whether or not there were unintended consequences. And so what they found was that the ESAP program was largely a success. There were no increased reports of drug use. There were no increased reports of loitering for syringes. There was increased safe syringe use. And pharmacists participating in this program largely supported it. The only downside that they really identified was that it wasn't reaching Black and Latino people who injected drugs. And so in response to that, there was the folks in the Center for Urban Epidemiologic Studies at NIM decided to integrate or test the Harlem ESAP Intervention Project. And this was a community level educational campaign that essentially basically informed on a community level informed community members about substance use as a disease. It informed them about ESAP, a number of things that would help destigmatize substance use, that would help people understand that there are resources that folks would need. And it really had a number of harm reduction principles. So South Bronx was the control neighborhood. And what they were able to show is that overall, among everyone who were attending pharmacies in Harlem, there was increased safe syringe use by about 100%. So it increased from about 13% to 32%. But this increase really spiked among Black people who injected drugs. So it increased from about 5% to 22%. So about 300% increase. What we learned in that, and this was a theme that I have learned throughout my entire career working with pharmacies, is that pharmacists always said, we want to do more. What else can we do? They would always say, but we can probably do something else to help. And so we began to test out, well, whether or not we can provide additional services for people who come into a pharmacy to buy a syringe for injection drug use, whether or not pharmacists could provide additional social, medical, and treatment referrals. And we were able to show that they were able to do this. They were satisfied with being able to do this. And there were reports of decreased unsafe syringe use in the population, the pharmacy clients who went to these PAT-linked pharmacies. So the next thing we decided was, why don't we scale this up? Why don't we see if we can do this on a larger scale? And so we started the PharmLink study. And this was a pharmacy randomized intervention among 88 pharmacies. I'm going to explain. We did quite a bit with these pharmacies, but all of this entire intervention was really informed and worked on by a number, like a really amazing working group. Our WIG at the time had healthcare providers. It had people from harm reduction services, health departments, community organizations. There were people with lived experience on the WIG. It was a pretty incredible group that really helped guide the research and what we were doing. So bear with me, this slide is a little busy, but I'm going to describe what this intervention did just by also giving you a little bit of information on the results, the overall results, right? Okay, so in the PharmLink study, we recruited 88 pharmacies, and they were randomized to one of three groups that can be represented by this small box that says the intervention group, the primary control group, and the secondary control group. In the intervention group, we recruited pharmacies and invited them to come to NIM. One evening, we provided food, and there was about a couple of hour seminar about substance use as a disease, harm reduction principles, role playing on how to engage with people who came in to buy syringes without a prescription, how to provide services, how to talk to them about social referrals, whether they needed a place to sleep, really digging in the nitty gritty. Following that, we then followed up at their pharmacy and did additional role playing in the pharmacy. The research team did that. And also we taught them, well, when they come in, and they would tell them about the study. And if they want to do the study, you just we have an appointment, and we will come in and we will do the interview for you. So this is a group that had a lot of work, a very intensive amount of intervention work that was asked of them during the intervention. The primary control group was pretty different. We went into their pharmacy and taught them how to recruit, how to tell people about the study in the same way, and told them we would come into the pharmacy to interview those folks. Now, naturally, because they are seeing how we interact with individuals, there was going to be some contamination of an intervention effect, right? And so their thoughts about the intervention would somewhat be guided by them seeing our harm reduction principles and interaction with clients who injected drugs. And so we also recruited a secondary control group. And in that group, we did nothing. We called them every 6 months and we asked them the same questions about support. And so we have 3 groups, and we wanted to look at whether or not they continue to support ESAP, this program that provided syringes without a prescription. We wanted to look at that over time. Now, a couple of things I want to highlight. As you can see, we start at pretty high support for the ESAP program among all of the pharmacies. We are starting at least 60%, right? And naturally, thankfully, this goes up among our intervention pharmacies significantly. Naturally, we saw that this went up drastically among the primary control group because of that interaction they would have with us, and that probably contaminated intervention effect. But for the secondary control group, we saw that sort of flatline, right? There wasn't much change over time. And so we do see pretty important differences. And despite this intervention group being asked to do so much, they still had such high levels of support for this type of work. Now, remember, our intervention group and our primary control group both recruited their pharmacy clients who came in to purchase a syringe without a prescription. And so we compared what the experiences were of those individuals in the intervention versus the primary control pharmacy. And what we were able to see is that those who were in the intervention pharmacy had lower receptive syringe sharing, lower perceptions of pharmacy syringe purchases as a barrier, increased reports of pharmacies as their primary syringe source, and increased 100% sterile syringe use. These were pretty impactful results for us. And we also learned that pharmacies wanted to do more. And this led us to say, well, what if we do HIV testing in pharmacies? Now, New York is just amazing, right? New York is always, it's always sort of been the like pinnacle of like what you want a city to be in terms of like access and people having services. And so even in Harlem during this time, HIV testing was around, right? Like people could get to HIV testing if they wanted to. But we said, well, let's just recruit a couple of pharmacies in Harlem and see what happens. And so we were really surprised by the response. I mean, we literally had to contact funders and say, we can't turn people away. There are a lot of people, they've heard that we're offering this in the pharmacy and they just want it from here, which I think speaks a lot to the disease neutral state of pharmacies and people just feeling very comfortable going into that specific environment versus going into a HIV service provider where you might, that is a very different experience for people. And so what we were able to see in this is that we were able to reach people who were at high risk for HIV transmission, racially minoritized people, people who use drugs, people who were not recently, had not recently received an HIV test, and people who lacked regular health care. But testing among our population was still only 40%. So we wonder, well, that's good, but it's not quite enough. And so we were wondering what was happening. So we thought, well, there might be some HIV testing stigma that's happening here. And so popular theoretical frameworks around stigma argue that you can reduce stigma by increasing access and by normalization. And so we thought, well, we can increase access in pharmacies. But we also wanted to test out whether or not we could normalize HIV testing by combining it with less stigmatized services. And so what we did, we recruited 3 pharmacies, one that offered HIV testing alone, another pharmacy that offered HIV testing with a video, and this video was one that our study team created the script for, we shot, and we basically had our study team actors, if that's what you wanted to call us. We were not professional, but we we were essentially showing clips where someone was being offered an HIV test and they were saying, yeah, I want to get screened for my health. I want to get all the tests. And they were like, HIV. They're like, yeah, that's everything. Like just treating it as a normal part of healthcare delivery and not decentralized from other chronic diseases, which HIV is, right? And then we recruited a third pharmacy where we offered the HIV testing, the video, and we included in that the other primary, excuse me, other um, disease screening. So we included glucose screening, cholesterol screening, and blood pressure screening. And so these less stigmatized diseases, we thought, well, we can, if we package HIV testing with these things, and what will happen. And so what we were able to see is that we could increase HIV testing uptake in pharmacies with this sort of normalized view of HIV testing by about 60%. And this is specifically among those who reported high HIV shame and blame. So people who actually reported that they had stigma, we were able to increase HIV testing by about 60% with this normalized view. So this is, that kind of ended a lot of where I was in New York. And I recently did a systematic review of what we were seeing in pharmacies across the HIV prevention and care continuum. And there have been a number of studies that have shown pretty good success and some tremendous success, particularly in the treatment realm, for being able to increase adherence. A number of those for syringe services, we see, more in this area. But one of the things that we really didn't see in how pharmacies could help with improving care across the HIV prevention care and continuum are data really among the populations that are currently driving HIV. That's Black men who are sexually minoritized men. That is trans populations. There weren't a lot of pharmacy-based studies that were really directed towards those populations. And also very few are in the South. And so that has led me to my current research program where we are really focused and honed in on the Southeast. The first study that I was grateful to do, well, my first NIH funded study, there was a CFAR study that was funded prior to this, but Prep Up Pharmacies is my first. It's a R34 funded by NIMH, where we really said there isn't a lot that we know about Black sexually minoritized men and whether or not they would even be open to accessing these services in pharmacies. So we started from the ground, really establishing formative research, right? Our first aim was to develop the formative research, then develop an intervention based on that data, and then test the intervention. And so in our formative phase, we really wanted to assess what was the support from both the pharmacy side and the population side, and how does the role of in the pharmacy influence perception of these services. And so one of our publications was a qualitative study among pharmacists as well as men who have sex with men. And the key themes were that there was strong support for in-pharmacy PrEP screening and delivery. Privacy and confidentiality, not surprisingly, were very important. But the pharmacists also really felt like, well, how are my staff going to be trained? They really wanted to make sure that there was adequate training. We also wanted to compare the pharmacy role. So as you know, when you go into a pharmacy, the technician is likely who's the person that you see and communicate with. So we wanted to understand support between the pharmacist and the pharmacy technicians. Both groups showed really strong support, but training was a concern for both groups. Pharmacists were really concerned about how they were going to be able to train their staff, and techs were also concerned about whether or not they would be able to get training, right? And who would have to pay for that, and whether or not that would be integrated into their day-to-day responsibilities. Infrastructure, pharmacists felt like, yeah, of course, we have space, or we can create space, we can do this. And so they felt that was okay. Pharmacy technicians, on the other hand, did not think of infrastructure in the same way. they were concerned about, well, what happens if we test someone and we get someone who's positive? Where do we send them? They were really concerned about the community relationships with how we take care of people beyond when they leave the pharmacy, right? And so nicely, like technicians were very clued into like this idea that we need to have wraparound, like we need to make sure that when they come to the pharmacy, they get something, but then when they leave, there's a plan for them. But both groups still had strong willingness to and wanted to figure out how we could provide PrEP in pharmacies. So we used that data. We developed a model for how we would integrate PrEP into a pharmacy in the Southeast. That is no small feat. If you are a pharmacist, you understand that the boards of pharmacy really dictate the scope of practice for each state. And so there in Georgia, as you all are probably not surprised, we have a more conservative board, as we have a more conservative of many things. And so we essentially created a model that would fit within the confines of what our pharmacist's scope of practice can be. And I'll talk a little bit more about that in a little bit. We were all ready to go. And then 2020 happened, and everybody knows what happened in 2020. And so we like immediately knew, well, our pharmacists are on a skeleton crew. There's no way we can implement an intervention right now. People are at home. It's not safe for people to be out. And so we had to sort of course correct. But we did quite a few things during this period to advance this work. And I'm going to talk about those, and then I'll come back to the intervention. So the first thing that we did was we wanted to see if we were able to implement the intervention, who would we be accessing? One of the biggest concerns that critiques that I received during while I was seeking funding for this work was, how do you know that people at risk for HIV are going to go to pharmacies? And I thought, well, people at risk for HIV go everywhere, right? Like, why wouldn't they be in pharmacies? I didn't understand that feedback. And so this was like a transitional phase. And we thought, well, why don't we just see who would be in the pharmacy and how many folks would be eligible for PrEP? So we recruited 2 pharmacies. And we did like a really modified training, a very small virtual training where we basically just told pharmacy staff how to tell people about that there was a study happening. And this flyer that is right here, it's also right here in my office. They would put this in their prescription pack, and there were posters that were set up in the pharmacy. And on this flyer, there was a little QR code here where they could scan with their phone. That would take them to a very short screener survey. And if they were eligible, it would take them to a longer 15, 20-minute social behavioral survey. So in a short 2-month period, between these 2 pharmacies, about 460 people took the screener survey. And then of those, 81 folks would have been eligible for PrEP due to their sex or drug use practices that in the pharmacy they wouldn't have been able to receive PrEP. So we were sort of surprised by how many folks would have been eligible for PrEP because of drug use, because we know a lot of the epidemic is being driven by sexual transmission. But we were also really happy to see that folks were really engaged with pharmacies, and they felt really comfortable with pharmacies, particularly for HIV. They were high reports of being willing to receive an HIV test in a pharmacy. A number of people had heard of PrEP, and so that was very good information for us to continue forward. We also looked at sort of what was like what were the barriers to them getting on PrEP for those who did know about this. And so this sample size is a little bit smaller, and I know all of these sample sizes are small. So obviously we have to do additional research, right? But the number one barrier was that they weren't knowledgeable about PrEP. But most of them had positive attributes about PrEP. They felt like people should take PrEP. Most people thought that PrEP was likely to work. That's this third bar here that is highly prevalent among most folks. And then, but there were some mixed. People did not think that they would be able to afford it. They thought it was going to be too expensive for them. They weren't sure people would take it consistently. And then people also thought, well, if you have PrEP, people are going to have more sex, right? So this common theme that if you give people more access to something, that they will engage in more behaviors, which generally doesn't pan out. But this group thought that. So the second thing that we did was we performed a national analysis of Black men who have sex with men from the American Men's Internet Survey. Overall, we were able to see that there was really high willingness to screen for PrEP in a pharmacy. There were 77% of folks reported this. And notably, there were not very many differences in who was willing. So we were happy to see that there was no differences in willingness by employment, by health insurance, or by sexual risk behaviors, right? Something that didn't really make sense that stood out to us was if you had a high school diploma compared to having less than a high school diploma, you were a little less likely. But what predicted comfort in getting, getting PrEP in a pharmacy was willingness to use PrEP in the first place, which would make sense, right? And then just comfort talking about PrEP in the pharmacy. So the final thing that we did during this period was we also wanted to examine the potential reach of pharmacy-based PrEP in the Southeast. So we combined data from AIDSview, from PrEP Locator, and we obtained all of the pharmacies in the U.S. Southeast from each of their boards of pharmacy. So I'm only going to show you data from Georgia today, which is why I only have the Georgia State Board of Pharmacy emblem here, but we gathered data from every board of pharmacy in the U.S. Southeast that would give it to us. And so first we created maps in ending the HIV epidemic areas across the U.S. Southeast for where the burden of HIV across these areas. So this is HIV incidence in the metro Atlanta area. I am from around here in Decatur, Georgia. As you can see, both Southeast and Southwest Atlanta are disproportionately affected by HIV in Atlanta. Whereas the northern areas, there is less HIV. Next, we use the data from PrEP Locator and we overlaid where we see PrEP clinics. And as you can see here in downtown, there are a number of PrEP clinics. Here in the northern areas, they are pretty spread out, but there are deserts of PrEP clinics in the southeast area and the southwest area of Atlanta. And then finally, to really understand the reach of pharmacies, we wanted to overlay where pharmacies were. Each of these blue dots represents 3 pharmacies. And visually, we had to do that so you could actually see the map. As you can see, pharmacies are equal opportunity. They are located everywhere. And so the difference between having this be your access and this be your access is stark. So there is a huge potential for us to be able to reach more people if we were able to offer these services in pharmacies. This is the same story for every state in the Southeast. Where we need the services, they are not, but we could have much more equitable distribution if we were to integrate pharmacies. So fast forward to now, we were finally able to do the intervention and we have some preliminary results, but we are just a little spoiled. We're going to recruit another pharmacy and hopefully we'll be getting more results that will add to this. So the model that we developed was a pharmacy and pharmacy technician led model where they inform their pharmacy client that there's a study going on. If they would like to participate, they can basically just go to an iPad, or they could use their phone and go to the screener, and if they were eligible, they could go to an iPad and take the longer survey. We had that set up in the pharmacy. That survey would basically tell them whether or not they were eligible for HIV testing in the pharmacy. Individuals had to do a self-HIV testing model. There were partitions that were created in this pharmacy with a noise machine. It was very private, and this was a space that we created in the pharmacy. Individuals had visuals in this area where they were able to do a self-collection, and then they gave that to the pharmacy staff, who then provided the interpretation of this HIV test as well as post-HIV test counseling. For those who tested negative, they provided a teleprep linkage, a teleprep prescription. They got on the phone, were able to call and get it done. And those who tested positive, we linked them with a community organization immediately for treatment. And so we also then examine PrEP uptake. So among the pharmacy staff, we wanted to assess a couple of things. So we did in the pharmacy training to teach folks how to do this, is because it's a lot, right? We learned that the training was acceptable, but getting folks to do the training took a lot of work on our end. It took, if you are a pharmacist or you know anyone who works in a pharmacy, it's very difficult for them to come off of their line, right? And so you have to, like, the training has to be really flexible. And so we did have a very flexible training. It was on Canvas, but they were really busy. And so it took a substantial effort for us to get them to complete this before we could start the intervention. We also provided CE credits for the training. And even with that, it still took quite a bit of work for us to get them to complete it. Now, on the model implementation, once they completed the training and integrated it into the pharmacy, they felt like it was acceptable. But their engagement with the model varied depending on what was happening in the pharmacy. Not surprisingly, if they had a lot of clients, they weren't doing anything. They were not telling them about this. And that makes a lot of sense, right? Also, we knew this going in, but they reiterated this a lot, that this would not work unless there was a consistent payment model. Now, because we were in the research setting, we were paying for the prescription for PrEP. But if there is no way for pharmacists to be reimbursed for the time that they are spending screening folks and talking to folks, and there's not a large reimbursement for the prescription itself, this would likely be unsustainable. So that is definitely something that we have to work on as we continue in the implementation science of this. So our preliminary results, though, about 247 folks were told about this that came into the pharmacy. 64 completed the screener. Most of those who completed the screener, about 72%, were eligible to go on to the longer survey. Among those who did the longer survey, which is 46 folks, this is where we start to see our ladder drop off. And you can see that I have a sort of a ladder image here. Only about 17.4% said that they will be willing to self-test in the pharmacy. And then our ladder drops off a little bit more. And among those who tested negative, there were only a couple who said that they were actually willing to get on PrEP. Most folks who said that they were unwilling felt like they did not need PrEP. Their risk perceptions were low. And we see this in clinics. This is risk perceptions, I think, is an issue that we are going to have to grapple with and figure out in the community for every setting, because that was the main reason that folks declined. So fast forwarding also to now, we have a couple of other studies that we've just begun. One is the PATH study, which we are developing the implementation science of scaling HIV testing and referrals in pharmacies in the Southeast on the policy, pharmacy, and client level. And so we are currently in the process of really starting to build the evidence of readiness of pharmacies in the Southeast. We're interviewing about 300 pharmacy staff across the Southeast to determine whether or not they're willing to do this, if their pharmacies are set up to do this, what would they need. We're going to combine those interviews with some qualitative interviews among pharmacy staff as well as board of pharmacy members. And then eventually we will test whether or not we can integrate HIV testing into pharmacies in the Southeast, and what are some of the barriers and facilitators. So we'll assess feasibility, acceptability, willingness, and uptake on the client level. And the other sort of puzzle piece to this, because I think in the Southeast, it's very difficult for us to actually get to this PrEP model. We have to, because of our legislation, we are going to test, if we can get HIV testing integrated, the next step would be, establishing this sort of PrEP linkage. So we are going to test whether or not we can formalize partnerships through collaborative practice agreements between pharmacists and PrEP prescribing clinicians. And so we are going to try to develop a template that pharmacies in the Southeast could grab from our website and adapt to their context. And they can identify from a database that we've given them, or from Prep Locator, who around them prescribes PrEP, and they could create this this CPA, collaborative practice agreement, so that when they do have someone who tests in the pharmacy, they can just call them and say, hey, listen, let's get them set up on PrEP. They are able to have that referral. And so this is in the absence of policies that really allow a natural linkage for pharmacists to be able to prescribe PrEP. This is sort of what we would have to do in the Southeast to make this work. So I'm going to end. I think I've done good on time. Our work so far is showing that pharmacies are viable solutions for reducing HIV and substance use related harms. These interventions we think can really move the needle on racial inequities and reducing racial inequities. But we do have to think about some important work system factors for sustained implementation, payment models specifically. And so we are really thinking through how to apply implementation science frameworks, because we think that is really the method that is going to best help us understand this sort of big problem. Our future steps are testing the scalability of these interventions, and we are doing quite a bit of work in the policy area right now, with trying to, both on the national and local level, with trying to get policies forward that really help folks. So thank you for your time. I want to thank all of the participants of our studies. I want to thank my collaborators, who are all amazing, my funders. And if anyone has questions today, we can answer them, but you can also reach me on email. I'm also on social media at Dr. Nat Crawford.
Thank you so much, Natalie. That was excellent.
Thank you.
So here at the HIV Center,